we are going to talk now about ovarian stimulation for IVF and ICSI. If we are talking about the critical steps or the cornerstones in IVF and ICSI, they are in order. Number one, handling of the gametes, which are the oocytes and sperms in the embryology lab. Number two is the embryo transfer procedure. And number three is the controlled ovarian stimulation. These are the three cornerstone steps in IVF and ICSI. We are talking now about the controlled ovarian stimulation in preparation for IVF and ICSI. The talk will include ovarian response or ovarian reserve testing, pre-stimulation treatment, ovarian stimulation protocols, adjuvant medications, monitoring of ovarian stimulation, triggering ovulation, and lastly, luteal phase support. The source of the material within this talk is from the ICSI guidelines for ovarian stimulation for IVF and ICSI published in October 2019, and the ovarian stimulation textbook edited by Professor Mohammed Abulghar and Professor Boutros Rizk, the last edition in 2022. Let's start with ovarian response testing. The normal responders, when we talk about the controlled ovarian stimulation, the standard conventional dose is between 150 and 225 international units of HMG or FSH. If the patient is expected to produce more than 18 oocytes, or she has more than 18 follicles, more than 11 millimeter on the day of trigger, she's categorized as high responder. If she is to produce less than or equal to 3 oocytes, or if she responds by less than or equal to 3 follicles on day of trigger, she's called poor or low responder. And if she produces between 4 and 18 oocytes, she's called average responder. The parameters which predict the ovarian response or the ovarian reserve: age, body mass index, antral follicular count, basal FSH, basal estradiol, anti-Mullerian hormone, basal inhibin B. If we are talking what is reliable and what is not reliable, the reliable ovarian test markers are the antral follicular count and the AMH. Other parameters, basal FSH, basal inhibin B, age, basal E2, and body mass index are not reliable or are not even predictor of ovarian response. So we will rely upon two parameters, which are the antral follicular count and the anti-Mullerian hormone. And this is the guideline recommendation. We have to rely on the antral follicular count and the anti-Mullerian hormone for prediction of the ovarian response. This is very essential for calculation of the initial dose of HMG or FSH in ovarian stimulation, and this is very essential to counsel the patient about her response. If we are talking about the normal values for antral follicular count and the AMH, for the antral follicular count between 7 and 15, this categorizes the patient as a normal responder. If the antral follicular count is less than 7 in both ovaries, this predicts poor response. If the antral follicular count in both ovaries is more than 15, this predicts high response. For the AMH, the normal level is between 1.1 and 4. If the AMH is more than 4 nanogram per milliliter, this predicts high response. And if the AMH is below 1.1, this predicts poor response. Serum estradiol, as I told you, this is not a reliable test for prediction of ovarian response. Serum progesterone, despite there are some research that states that the serum progesterone basally, when it exceeds 1.5 or 1.6 nanogram per milliliter at the onset of stimulation, this predicts reduced pregnancy rates, but the evidence beyond this research is sparse, and this is not recommended by the ICSI to be checked on day 2 of the cycle. Some research supports this, but the evidence beyond this research is not adequate enough to recommend it. What do we need for pre-stimulation therapy? Using estradiol or progestin alone is not recommended before antagonist protocols, and it actually reduces the ovarian response and reduces pregnancy rates in antagonist protocol in particular. However, the use of combined oral contraceptive pills can be used in long agonist protocol, but it cannot be used in antagonist protocols. We usually use the combined oral contraceptive pills to schedule the cycle, to have exact dates, to give to the patient to come at exact dates, not to wait for her menses, which can start on the weekends. If we are to use the combined oral contraceptive pills, it's better not to use it before antagonist protocol because it is associated with reduced pregnancy rates, but it can be given before long agonist protocols. The controlled ovarian stimulation protocols, first, I would recommend that every clinician who manages ovarian stimulation in preparation to IVF and ICSI to use charts similar to that presented. This is very essential in monitoring the ovarian response, monitoring the doses, to state the notes to the clinician, stating the ovarian stimulation cycle within this chart helps a lot in improving the efficacy and adequacy of ovarian stimulation. This is an example of a real folliculometry chart. As you see, we state the dose of the LHRH, the dose of the HMG-FSH, the response of ovarian stimulation in terms of number of follicles and size of follicles. We state here the endometrial thickness, and here if we are to monitor the estradiol and LH during the cycle, the time of HCG trigger, you can see the whole stimulation cycle. Every check you see the patient, you can see how you are going well with the ovarian stimulation cycle. We have 4 main protocols which are currently practically used in ovarian stimulation: the long GnRH agonist protocol, the GnRH antagonist protocol, short GnRH agonist or the flare protocol, and the newly developed Progestin-Suppressed Protocol. In the long GnRH agonist protocol, we start the GnRH agonist on cycle day 21, and we keep the GnRH agonist after the menses starts. On cycle day 2 or cycle day 3, we start stimulation by HMG or FSH till we reach the maturity, and then we give trigger. If we are using the long GnRH agonist protocol, we have only HCG to trigger. We cannot use any other agent. In the GnRH antagonist protocol, we start on cycle day 2 stimulation by HMG or FSH plus or minus oral inducing agents. And on cycle day 7, if we are using the fixed protocol, or when the follicle reaches 13 or 14 millimeter, if we are using the flexible protocol, we start the GnRH antagonist, 1 ampoule per day, hand in hand with the ovarian stimulation medications till we reach the maturity. In the GnRH antagonist protocol, we can use either the HCG or the GnRH agonist trigger. We cannot use the GnRH agonist for triggering the long GnRH agonist protocol because the receptors are already depleted by the long administration of the GnRH agonist. So we can use the GnRH agonist trigger in the GnRH antagonist protocol, but not in the GnRH agonist protocol. In the flare or short agonist protocol, we start stimulation on cycle day 2 by either HMG, FSH alone, or with oral agents. And we start low dose GnRH agonist, which is half or third ampoule of tryptophan or decapeptyl, half ampoule every day, or third of an ampoule every day. We give trigger only by HCG, as once again, the GnRH agonist receptors are already depleted. So we cannot trigger by GnRH agonist in the short GnRH agonist protocol. We use only the HCG for triggering ovulation. The value of this short or flare protocol is to make use of the initial agonist activity of the GnRH, and then we make use of the inhibitory or suppressive effect of the GnRH agonist to prevent premature ovulation. In the progestin protocol, we start stimulation on cycle day 2, and we start the oral progestin either steronatenor or dufaston twice per day on cycle day 1 or cycle day 2, and we keep the oral progestin till we reach the mature follicles, and we can give in this protocol either the HCG or GnRH agonist for triggering ovulation. This is very useful and low-cost protocol for poor responders, for women at high risk of ovarian hyperstimulation, particularly when we have shortage of the GnRH antagonist, as we have these days. We have in Egypt these days shortage of the GnRH antagonist, which is a cetrotide. So we can use this protocol as an alternative or substitute to the GnRH antagonist protocol. Again, we can use this protocol in poor responders, particularly if we do multiple stimulation cycles. Sometimes in poor responders, we need to do stimulation in more than one cycle. So it's a low-cost protocol that can give the chance to the patient to do multiple stimulations without paying too much money for the cetrotide or the GnRH antagonists. What are the gonadotropins used in controlled ovarian stimulation? The gonadotropins include the HMG, which is a human menopausal gonadotropin, which is a combination of both FSH and LH, the FSH alone, LH alone, and the human chorionic gonadotropin. We use the human chorionic gonadotropin for ovulation triggering. We have only 2 preparations, the Hormone, which is purified urinary HCG. It's given only intramuscular, and the Ovitrel, which is a recombinant form of HCG. The difference between urinary and recombinant HCG is in 3 aspects. Number 1, the recombinant is advantaged by absence of urinary protein. Urinary protein is antigenic protein, and this absence allows for subcutaneous administration. The more you have antigenic protein, the more opportunity to give subcutaneous injections. The urinary, whether highly purified or less purified, are preferably to be given intramuscularly to avoid antigenicity of the urinary protein. The second advantage of the recombinant preparations is the consistent supply. We do not rely on women who give their urine to extract the gonadotropins from it. We rely on recombinant technology to synthesize such hormones, so we have consistent supply. The third advantage is the less batch-to-batch variability, which affects the efficacy. Urinary-derived gonadotropins are disadvantaged by having high batch-to-batch variability regarding the efficacy. The HMG preparations are only urinary extracted. The less purified, which are given only intramuscular, are the Merional and the Minogon. The highly purified preparations can be given either intramuscular or subcutaneous, which are the Meriofert and the Minopure. The FSH highly purified preparation is the Fostimon and Purigon. The recombinant preparation is Gonal-F and Gonapure. And LH is present only in recombinant form, which is the Lovaris. Regarding the guidelines, the current guidelines see no difference between FSH and HMG in efficacy for ovarian stimulation in preparation to IVF and ICSI. The use of whether urinary FSH or recombinant FSH is equally effective and equally recommended. These are the ICSI guidelines for ovarian stimulation in preparation for the IVF and ICSI. The use of highly purified FSH and HMG, again, in the long agonist protocols are equally effective and equally recommended. Addition of the recombinant LH to recombinant FSH is not recommended when compared to HMG in GnRH agonist protocols. So if we are to use combined FSH and LH, it's better to use HMG rather than to use combined recombinant LH and recombinant FSH. These are the recommendations of the ICSI. But we have some practical tips that go against the ICSI recommendations in some points. Number one, in the long GnRH agonist protocol, it is recommended to start with recombinant FSH or highly purified FSH alone for the first 5 to 6 days. And then when we have good response, we can add the HMG. This is particularly useful in women with with high basal LH. Sometimes when we do the basal LH on cycle day 2 or 3, we have high basal LH despite we are already downregulated with the GnRH agonist in long agonist protocol. If we have high basal LH, it's preferable to start with FSH alone, whether recombinant or highly purified FSH. Again, in disagreement with the recommendations of the ICSI, we prefer to adjust the ratio of the FSH and HMG according to serum LH monitoring. This means that if we are calculating the dose of the gonadotropins to be 225, which means 3 ampoules of the gonadotropins, we can adjust the ratio of the FSH and HMG, that is to give 1 ampoule of FSH and 2 ampoules of HMG, or to give 2 ampoules of FSH and 1 ampoule of HMG, or 3 ampoules of HMG, or 3 ampoules of FSH. These are all will sum to 225 international units of gonadotropins. The ratio between FSH and HMG highly depends on the LH monitoring, particularly when we don't have good initial response. We can modify the ratio between FSH and HMG along the stimulation cycle according to the serum LH monitoring. If we have high basal or ongoing serum LH, it's better to increase the ratio of the FSH. If we have low basal LH or low or ongoing LH, it's better to increase the ratio of the HMG on the expense of FSH in the stimulation cycle. How to estimate the initial dose of gonadotropin dose? I have to emphasize that the calculation of the initial dose of gonadotropin is very, very important because we don't prefer to fluctuate or modify the dose of gonadotropins during stimulation or after stimulation starts. We have to concentrate on calculation of the initial dose of gonadotropin because the more stable you have gonadotropin dose, the more chance you have good quality and high numbers or adequate numbers of oocytes. Try not to fluctuate or increase or decrease the dose as far as possible during the stimulation cycle. So concentrate and focus and take your time in calculation of the initial dose of gonadotropin. The standard initial dose is 225 international units per day. We decrease the initial dose in women known to have PCOS or have previous high response to standard dose, or if she has ovarian response tests that predicts high response, that is to have intrafollicular count more than 15 or AMH more than 4 nanogram per milliliter. If we have these parameters, the initial dose should be reduced to 150 rather than 250 international units per day. On the contrary, if the patient is above 35 years old, if she had previous poor response to the standard dose, if she has intrafollicular count below 7 or AMH below 1.1, if she's known to have endometriosis or diminished ovarian tissue, it's preferable to increase the dose to 300, 370, or even 450 international units per day. This means 4 ampoules, 5 ampoules, 6 ampoules per day. But this needs some exception in women who are known to have extremely poor response, women who would inevitably produce less than or equal to 3 oocytes. That is, they are having AMH below 0.1, the intrafollicular count is below 3, or very small ovarian volume. Such patients would not benefit from high doses of gonadotropins. The ICSI guidelines does not recommend to increase the dose beyond 300 international units per day, and the doses above 150 are questionable. So in predicted poor response, we can increase the dose, but if we have prediction or anticipation of extremely poor response, the patient will not produce more than 3 oocytes anyhow. There is no value of increasing the dose of gonadotropin. You will cost the cycle. You will add extra hormones to the patient without any benefit. So in calculation of the dose for the poor responders, weigh the benefit against the risk. If you have parameters that predict extreme poor response, do not increase the dose. But if you have parameters like the age, AMH is low but not below 0.1, the intrafollicular count is below 7 but not below 3, if you have adequate ovarian tissue volume by ultrasound, you can increase the dose. Otherwise, there is no value of increasing the dose beyond 300 or even 150 international units per day. And it's preferable for such patients to do stimulation on multiple cycles to get 2 or 3 oocytes each cycle and do more than 1 cycle to collect the adequate number of oocytes you need. How to select the stimulation protocol? The ICSI guidelines does not see and does not recommend GnRH agonist protocol is safe for the PCOS women and recommends to use the GnRH antagonist protocol for safety purpose. The GnRH antagonist is also recommended for women who have no PCOS but are known to have high response from previous cycles. If we are to use the GnRH agonist protocol for any reason, like availability of the drug, you have to reduce the dose, as we mentioned, to the initial standard dose should be no more than 150. And sometimes in women who have very high AMH or who have previous ovarian hyperstimulation on doses like 150 per day, we even reduce the dose to 775 or 87 international units per day. There is no difference in the clinical pregnancy rate or the live birth rate between the GnRH antagonist and GnRH agonist protocol in normal responders. In the poor responders, both GnRH antagonist protocol and GnRH agonist protocols are equally effective, and I would recommend that we use either the short or flare GnRH agonist protocol or the new Progestin-Suppressed Protocol for such women. As I mentioned in the stimulation protocols, addition of an oral agent like clomiphene citrate or aromatase inhibitor to the non-pituitary suppressed protocols, which are the GnRH agonist, the short GnRH agonist, and the progestin-suppressed protocols, may boost the response. Adjuvant treatments. We have two categories of adjuvant treatments. Categories that are not recommended by evidence and are not effective by practice, which is the use of the testosterone and the dihydroepiandrosterone acetate. And we have group of adjuvant medications which are supported by practice but are not supported by evidence. They might be useful. We have two medications which lie in this category. The metformin in PCOS women. The evidence says it's not associated with increased pregnancy rate, but we have practical and some sparse evidence that it reduces the risk of ovarian hyperstimulation. So I would recommend to add metformin in PCOS women during stimulation, particularly if she has high body mass index above 27 kilogram per square meter surface area. The second drug is the growth hormones. There is conflicting evidence regarding the efficacy of growth hormone in poor responders. I would, if the patient is desperate, if the patient is extreme poor responder, if she has multiple previous failed cycles, I would add the growth hormone, but beware of two points. Number one, pre-treatment growth hormone is totally ineffective. If you are to start growth hormone, started during the mid-stimulation, that is on day 7 or day 8. Earlier onset of growth hormone will add cost to the cycle without adding any benefit. The second point you have to be aware of is that growth hormone addition falsely elevates the serum E2 level. So do not rely on the serum E2 level for triggering ovulation in women receiving growth hormone. Growth hormone can falsely elevate the serum E2 level. So rely on the size of the follicles regarding the decision when to trigger if you are using growth hormone. How to monitor stimulation? Usually we monitor stimulation with ultrasound, as I will tell you in a few minutes when to trigger, but I'm talking now about how to monitor during using the serum hormones. The evidence states that measurement of serum estradiol and measurement of the estradiol, progesterone, and LH during the ultrasound will not add to ultrasound monitoring. This is the evidence, but beware, this is conditional recommendation, which is not strong recommendation. From practice, particularly if you are a beginner or not expert enough to rely only on the ultrasound, it's preferable to measure serum E2 and LH in parallel to the sonographic monitoring. This has some important values. Number one, to adjust the ratio of the FSH and HMG, as I told you a few minutes ago, according to the LH level monitoring. Number two, beware that LH assay is only useful in pituitary suppressed protocols. It's no use to monitor LH in the GnRH antagonist or the flare protocol because the LH is not suppressed. Number 3, proportionate serum E2 level and number of the detected follicle is a good predictor of mature follicles. If you have too low E2, despite the size of the follicle is approaching or reaching the mature size, be aware that you may retrieve immature follicles. You have to correlate between the serum E2 level and the size and number of the follicles before you take the decision to trigger. A mature follicle should roughly produce around 200 nanogram per milliliter of estradiol in the circulation. So correlate between the measured serum E2 and the number and the size of the follicles you see by ultrasound, and make sure that you have adequate E2 in proportion to the observed follicles before you take the decision to trigger. But beware when you measure the serum E2, if you add the estradiol valerate, which is the white tablets of the cycloprogenova or progenova, beware that such medication will falsely again elevate the E2 as the growth hormone. Again, serum progesterone level is not recommended by the ICSI to be monitored, but we have some sparse evidence and we have practical experience that serum progesterone levels above 1.3 nanogram per milliliter on the day of trigger before you give the triggering agent is associated with lower pregnancy rate if you are intending to do fresh transfer. Therefore, if you have serum progesterone level above 1.3 before giving the trigger, it's better to counsel the patient about freezing all embryos or to counsel her about a lower pregnancy rate if she undergoes fresh transfer. These are all practical points that are not supported by the ICSI guidelines, but again, the ICSI guidelines are regarding this point in particular is conditional and depends on expert opinions rather than strong evidence from studies. During ovarian stimulation, you have to look at the endometrial thickness. Again, the evidence does not support monitoring of the endometrium except on the day of triggering ovulation. Again, these are conditional and good practice point recommendations that are not supported by studies or adequate research. From practice, it is practically recommended to monitor the pattern and thickness of the endometrium with ovarian stimulation if you are intending to do fresh transfer. The target is to have trilaminar pattern of the endometrium and endometrial thickness above 8 milliliter on the day of trigger. This is very essential for successful outcome in fresh transfer. If you are looking at the endometrium during stimulation and you are detecting poor or sluggish endometrial development, you can add estradiol valerate supplementation, which are the white tablets of the progenova. Beware that you shouldn't give this supplementation too early during initiation of stimulation because they will suppress the efficacy of the FSH and will hinder the stimulation itself. If you are to start the estradiol valerate tablets, you have to wait till you have the size of the follicles beyond 12 or 13 millimeters. Criteria for triggering ovulation. The evidence does not support the use of estradiol or the estradiol follicle ratio alone to decide when to trigger. The evidence sees no value of such measurements, the estradiol or the estradiol follicle ratio. But again, this is conditional and good practice point recommendation. The decision of the timing for triggering is very complicated and one of the very critical decisions during stimulation. It's multifactorial. It depends upon the duration of stimulation, the patient burden, cost, number of the follicles. From practice, consider the following before triggering. Number one, the duration of stimulation should not ideally be less than 11 days. Sometimes when you start stimulation, you reach the size of the mature follicles on day 8 or day 9 of stimulation. Do not rush for triggering. Prolong the stimulation, extend the stimulation for further 2 or 3 days before you trigger, even if the follicles reach beyond 20 or 22 millimeter in dimension. But this is not recommended when you are using the GnRH antagonist protocol. Once you have a number of follicles reaching more than 18 millimeter, it's better to trigger even if you have low duration of stimulation, because you are then at risk of premature ovulation. Again, consider the proportion between serum E2 level and the number and size of the follicles. Each mature follicle should produce 200 nanogram per milliliter in the circulation. So correlate between the measured serum E2 and the size and number of the follicles, and do not give trigger unless you have adequate or close to be adequate proportion. Again, if in the previous cycle response you have retrieved a high proportion of immature oocytes, it's better to prolong stimulation for further 2 or 3 days before you trigger. What do we use for triggering ovulation? We have urinary HCG, which is a hormone. The standard dose is 10,000 international units, which is 2 ampoules. The lower dose, which is 1 ampoule, 5,000 international units, and higher doses, which is 3 ampoules or 4 ampoules. The recombinant HCG, which is the Ovitrel, the standard dose is 250 international units, which is equivalent to 6,500 international units of the hormone. And we have the GnRH agonist, which are the tryptophan or decapeptide. The standard dose is to give 0.2 to 0.4, which is 2 or 3 or 4 ampoules of tryptophan or decapeptide. The recombinant LH is not recommended at all for triggering ovulation. So we give either the urinary HCG, the recombinant HCG, or the gonadotropin releasing hormone agonist, which are the tryptophan or decapeptide. These are the 3 agents that are used for triggering ovulation. The evidence sees no difference between recombinant and urinary, and the evidence sees no difference in reducing the dose of HCG to 5,000 international units, which we usually use in patients predicted to have high response in order to reduce the risk of ovarian hyperstimulation. Again, practice differs to extent from this recommendation. Both recombinant HCG, which is the Ovitrel, and reduced dose of urinary HCG are associated with relatively lower numbers of retrieved oocytes and relatively lower proportion of mature oocytes. So it is not recommended to use the recombinant HCG or the reduced dose of urinary HCG unless you have clear, real risk of ovarian hyperstimulation. The use of GnRH agonist protocol is recommended in women at risk of ovarian hyperstimulation, but you have to be aware that fresh transfer is not recommended in such cycles. GnRH agonist protocol as a triggering agent should only be given when 3 criteria are all fulfilled. Number 1, in a non-GnRH agonist covered cycle, because in GnRH agonist cycles, the receptors are already depleted, so the GnRH agonist will not be effective as a triggering agent. Number 2, in women at real risk of ovarian hyperstimulation. Number 3, when freeze-all policy is intended. Again, if you give GnRH agonist alone as a triggering agent, it is not recommended at all to do fresh embryo transfer in such cycle. Dual trigger means to give both GnRH agonist and the reduced dose of urinary HCG. This can be considered in women with previous poor response. Sometimes when you give the standard dose of HCG alone or GnRH agonist alone, sometimes you have a low number of retrieved oocytes or high proportion of immature oocytes, in the subsequent cycle, if you do dual trigger using both agents, sometimes you have adequate response in terms of adequate number of oocytes and adequate number or adequate proportion of mature oocytes. Women at risk of ovarian hyperstimulation in whom fresh embryo transfer is intended, but the risk of ovarian hyperstimulation is intended to be reduced, you can add low dose of urinary HCG to the GnRH agonist in order to do fresh ET, but I wouldn't recommend this at all. If you are using GnRH agonist and reduced dose of HCG, the endometrial development is not good, and the pregnancy chances in such a cycle will be reduced. Finally, we are talking about the luteal phase support. We have the progesterone, which is a recommended regimen or agent for luteal phase support. We have intramuscular route, subcutaneous, vaginal gel, vaginal micronized progesterone. All are effective as luteal phase support in IVF and ICSI. The doses for the intramuscular is 50. The preparation we have in Egypt is 100 milligrams. So if you are to give intramuscular progesterone, you can give it every other day, which is a Progestin ampoules. The subcutaneous preparation is the Prolutex. The dose is 25 milligram once daily, 1 ampoule per day. We had the vaginal micronized progesterone before, which is a Utrogestan. And we have the Progestin-Suppressed. If you are using the Progestin-Suppressed, you can use 400 milligram twice per day. Progesterone should be started in the window between the evening of the day of oocyte or day 3 oocyte retrieval. The current practice recommends to start the progesterone supplementation either on the day of oocyte retrieval or on the next day, no later than this day, either on the day of oocyte retrieval or on the second day, and should be continued until the pregnancy test. I would recommend to continue the progesterone supplementation till the luteal placental shift, which usually happens or occurs at 9 to 10 weeks of gestation. HCG is equally effective to progesterone in doses 1,500 international units, but is not recommended because it increases the risk of late onset ovarian hyperstimulation. Thank you. كان في سؤال عن ليه ال recombinant LH is not recommended for triggering ovulation. ال results from the studies ان هو ال retrieval of oocytes والmaturity بتبقى poor مع recombinant LH. We either use HCG whether urinary or recombinant أو GnRH agonist. إنما ال recombinant LH retrieve lower number of oocytes و high number of immature oocytes. كان في سؤال برضو عن أو كومنت عن ال LH إن هو ال elevated LH في pre-ovulatory period. فعلا both ال high ال too high LH أو too low LH، يعني كان في بعض الإيفيدنس برضو عن ال LH اللي هو بينزل تحت ال 0.5 وال LH اللي هو بيفضل persistently high، الاثنين associated with lower pregnancy rate. وعشان كده في الحالتين دول الحالة اللي بيبقى فيها very high LH أو very low LH it's better to counsel the patient for freeze all policy. البروجستين برايم بروتوكول is excellent. هو عيبه الوحيد بس ان احنا خلاص بنفقد الفرصه في الفريش ترانسفير، لكن لا هو excellent alternative to the antagonist protocol, low cost protocol اليلد بتاعه في ريتريفال اوف اوسايتس هايل، فهو اكسلنت بروتوكول يعني. بس طبعا له البيشنتس اللي هم ات ريسك اوف ovarian hyperstimulation او البور ريسبوندر بيشنتس. في الريسك اوف ovarian hyperstimulation طبعا عشان اقدر ادي تريجر بالجي ان ار اتش اجونست، وفي البور ريسبوندرز عشان اعمل لها لو كوست سايكل فاقدر اعمل لها ستيميوليشن على اكتر من سايكل وريتريف اوسايتس. البروجستيرون ليفل في الاي في اف سايكل، في سؤال عن البروجستيرون ليفل في الاي في اف سايكل. البيزل ملوش قيمه قوي، البيزل اللي هو بيتعمل مع بدايه الاستيميوليشن ملوش قيمه قوي، لكن اللي هو بيتعمل في التيرمينال دايز اوف سايكل قبل التريجرنج ده مهم. وده لما بيعدي كات اوف ليفل معين، كات اوف ليفل ده عليه اختلاف، لكن هو لو عدى ال 1.3 وفي بيبرز ان هو 1.8 يعني، ده بيبقى معاه associated with lower chances of pregnancy. لو البيشنت عندها limited numbers of embryos I would prefer انها تعمل freeze all وتنقل في سايكل تاني. لو عندها high number of embryos والاندوميتريوم شكله بالالترا ساوند كويس، ممكن نديها الشانس اوف فريش، بس لازم في الناس اللي فيهم هاي بروجسترون ده يبقى عندنا فروزن امبريوز، لازم يبقى عندي فروزن امبريوز لان الشانسز اوف بريجنسي هتقل مع الاليفيتد بري تريجر بروجسترون ليفل. في طلبات عن البريبريشن للفروزن امبريو ترانسفير، خلاص ده ان شاء الله يبقى ايه التوك الجاي باذن الله عن الفروزن امبريو ترانسفير بريبريشن يعني. في سؤال عن الليكتشر ريكوردد، ريكوردد، وهيبقى من خلال بقى البوستر بيز اللي هي الشركه الراعيه والميديكال ريب دكتوره ياسمين، ان شاء الله هي تكوميونيكيت معاكم لو حد عايز يريسيف الريكوردنج بتاع التو ليكتشرز، مفيش اي مشكله طبعا ان شاء الله. طيب في سؤال how to improve AMH اقل من 35 سنه with low ovarian reserve. هو احنا ما عندناش يعني ما عندناش حاجه تحسن الاوفيريان ريزيرف، مفيش اي ميديكيشنز او انترفنشن هتحسن الاوفيريان ريزيرف. هو الفكره احنا بنتعامل مع الاوفيريان ريزيرف القليل ده ازاي؟ بالسelection of the protocol, selection of the proper dose، وبعض الاحيان بنحتاج نعمل multiple stimulation cycles هو الامبريو بولينج او الامبريو باسكت. هيبقى فيه توك ان شاء الله منفصل، طبعا انا اتكلمت عليه سوبرفيشالي كده شويه، لكن هو المفروض البور ريسبوندرز دول هيبقى ليهم توك لوحده كده how to handle patients for poor response with poor response. بس بشكل عام ما عندناش حاجه خالص تحسن الاوفيريان ريزيرف، ولا فيتامينز ولا سبلمنتس ولا الدي اتش اي اي ولا البلازما ولا اي حاجه من الكلام ده خالص. هو الاوفيريان ريزيرف القليل هيفضل قليل، هو الفكره بس انت هتتعامل معاه ازاي. البروجستين برايم بروتوكول لا، لما الاوفيريان هايبر ستيميليشن بيحصل بسبب الاتش سي جي تريجر ده لو هو الايرلي اونست، او بسبب البريجننسي نفسه لو ليت اونست. يعني اوفيريان هايبر ستيميليشن يساوي اتش سي جي سواء اكسوجينس لو اديناها كتريجرنج ايجنت او في ليتير فيس سبورت، او اندوجينس لو حصل بريجننسي. البروجستين برايم بروتوكول لو انا مديه علشان افويد الاوفيريان هايبر ستيميليشن، خلاص انا مش هدي تريجرنج بالاتش سي جي، هعمل تريجرنج بالجي ار اتش اجونست، كده هيبقى في نيل ريسك، زيرو ريسك اوف اوفيريان هايبر ستيميليشن. مفيش هايبر ستيميليشن بيحصل مع الجي ار اتش اجونست تريجرد سايكلز. في سؤال عن ال DHEA، لا زي ما قلت لكم DHEA does not improve ال MH does not improve ال ovarian reserve. احنا في بعض الاحيان بنديه امبيريك كديسبريت كده تشويس يعني للناس اللي فيهم بور ريسبونس، لكن بنبقى قايلين للبيشنت ان ده حاجه كده يعني ايه سبلمنتري، ممكن وممكن لا اتحسن، بس من البراكتس ومن الايفيدنس لا مش بيحسن. الجروث هرمون الدوز بتاعته 4 انترناشونال يونت، امبول واحد بير داي. زي ما قلنا ما بنبتديوش بلاقي انا في ناس بتكتبه لوحده كده من غير يعني بيشنت جايه كده ببور فيرن ريزيرف، تكتب لها جروث هرمون لوحده كده، تاخده كده شهر ولا حاجه قبل الاستيميوليشن. ده ملوش اي قيمه. وكمان حتى لو احنا ابتدينا استيميوليشن ما بنبتديوش من اول يوم، ملوش قيمه برضه. هو بنبتدي من اليوم السابع او الثامن من الاستيميوليشن. ناخد بالنا زي ما قلنا في التوك ان هو ممكن يعلي الاي 2 فولس. طب واخد بالي وانا ببص على الاي 2 ليفل ان ده ممكن يبقى فولسلي اليفيتد بالجروث هرمون. آه في بروجستيرون بروتوكول. لا، البروجسترون بروتوكول احنا بنعمل ستيميليشن عادي بالاتش ام جي والاف اس اتش، وممكن معاهم اورال ايجنت زي الكلوميد او الليتروزول. بس بدل ما بنستخدم بقى جي ان ار اتش اجونست او جي ان ار اتش انتاجونست فور بيتيوتري سبريشن، بنستخدم بروجستيرون، بنستخدم البروجستين اللي هو يستيرونيت نور قرصين في اليوم، يدوفاستون قرصين في اليوم. من اليوم الثاني اللي هو مع بدايه الاستيميليشن نفضل ماشيين عليه لحد اليوم بتاع التريجر. هو ده اللي بيعمل بيتيوتري سبريشن، يمنع البريماتيور ال اتش، اللي هو ده التارجت بتاعنا اصلا في الكنترول ستيميوليشن. التارجت بتاعنا في الكنترول ستيميوليشن ان احنا نعمل سبريشن لل اتش ال اتش عشان ما يحصلش بريماتيور ال اتش سيرج، وما يحصلش اوفيوليشن قبل ما نوصل لليوم اللي احنا هنعمل فيه تريجر، وبعديها نعمل اوسايت ريتريفل. البروجسترون او بروجستين برايمد بروتوكول ده بنستخدم البروجستين as an alternative to the GnRH agonist و antagonist to suppress the pituitary، لكن مش للاستيميليشن. في سؤالين للدكتور طارق كده، يتفضل ان شاء الله يجاوب عليهم. طيب low AMH can lead to premature ovarian failure. هو predictor شويه طبعا، يعني احنا لما نلاقي واحده سنها صغير وال AMH بتاعها قليل اقل من 1، ده طبعا بريدكتور. عشان كده احنا دايما بنبقى urging such patients ان هم to undergo ICSI، لان هي ممكن يبقى فيها progressive pathology في الاوفري، وده هيبوز هير ان هي to get into premature ovarian failure soon. هو بريدكتور للبريماتيور ovarian failure. بس هيحصل امتى وهيحصل بشكل متسارع ولا قدامه لسه شهور او سنين؟ مفيش حاجه تقول كده يعني. شكرا جزيلا يا جماعة على حضوركم جميعا. و يعني ممكن من خلال دكتورة ياسمين برضو أي حد عنده أي استفسار أو أي اقتراحات بخصوص المواضيع اللي جاية طبعا ينورنا ويشرفنا. وإحنا إن شاء الله هنرتب لأكتشوال ميتنج كمان قريب بإذن الله، يعني عشان نتشرف بيكم جميعا إن شاء الله. السلام عليكم، بالتوفيق جميعا.